Well, today we're going to be talking about NMO and MOG. NMO, neuromyelitis optica, and optic neuritis associated with a myelitis, and MOG, myelin oligodendrocytic glycoprotein. You need to know about NMO and MOG in patients with optic neuritis because the most common cause of an acute unilateral loss of vision with an RAPD and a normal fundus or a swollen nerve in a young person is an optic neuropathy, and that most common optic neuropathy is optic neuritis. And normally, multiple sclerosis is the most common cause of optic neuritis, especially in young females who are Caucasian. And the old paradigm was we would get the clinical history and do the exam. We would do an MRI scan. It would show enhancement of the optic nerve. And what we're looking for is periventricular multifocal white matter lesions, which may or may not enhance, consistent with demyelinating lesions like the Dawson's fingers. And if the MRI was negative for multiple sclerosis, we'd be good. You could give intravenous steroids, you could give nothing, you could give oral steroids, and the optic neuritis treatment trial showed intravenous steroids sped the rate of recovery but didn't change outcome. So that was the end of that. However, now you need to know that if the MRI scan is negative for multiple sclerosis, that might not be a good thing. Because what it means is not likely to be MS, not zero, but less likely. And if it's not MS, it could be something that looks like MS and is producing the optic neuritis, but is actually something far more sinister. Antibodies against the aquaporin 4 channel, or antibodies against myelin oligodendrocytic glycoprotein. And what that means for you clinically is the outcome, the treatment, and the prognosis are going to be completely different from an optic neuritis related to MS versus an optic neuropathy related to NMO or MOG. And so when someone has optic neuritis and their MRI is positive for MS, we just do what we always did. But if it's negative for MS, or if there are features that suggest that it is NMO or MOG, for example, clinically, with patients with NMO, they might have intractable hiccups, or nausea and vomiting unexplained, or symptomatic narcolepsy. These are super weird questions that we have to ask every patient with optic neuritis now that we didn't have to ask before. We're going to be asking and looking for myelitis in those patients, and if the antibody, NMO IgG, aquaporin 4 channel, is positive, not only do we have to consider intravenous steroids in the acute phase, but thinking about plasma exchange, or IVIG, followed by chronic immunosuppressive therapy like rituximab to prevent the myelitis from coming if a person is NMO positive. Likewise with MOG, even though it's not as bad as NMO, it's kind of like NMO light. If we see longitudinally extensive enhancement on the MRI after gadolinium, or if it's chiasmal disease, or if it's bilateral, or if the disc is swollen, or if there's anything about this optic neuritis that is atypical clinically, an older person, a non-Caucasian person, a non-Caucasian older Asian male, we should be thinking about things that look like optic neuritis but are not from MS, and those are the patients we're going to do NMO and MOG on. So, in summary, yes, optic neuritis is still the most common cause of an acute unilateral optic neuropathy in young people. Yes, still do an MRI looking for enhancement of the nerve. And yes, keep looking for MS. But if we don't see MS, we see something weird about the enhancement, bilateral, longitudinally enhancing, or chiasmal. Or if we don't see any evidence of MS and the patient has any of those weird symptoms, intractable hiccups, nausea and vomiting, myelitis symptoms, symptomatic narcolepsy, or if the imaging shows perineuritis or shaggy enhancement, then we should be ordering NMO and MOG. But if it looks like a duck and flies like a duck and quacks like a duck, it's probably multiple sclerosis.